Okay, let us continue. Indicate if you can hear me. All right, so next we're looking at chapter 17, which is neurologic emergencies. The focus of this chapter will be on stroke, headaches, seizures, and patients with altered mental status. So, introduction. Stroke is the fifth leading cause of death and the leading cause of adult disability in the United States. The numbers might be similar here in Jamaica or maybe higher. Common in the geriatric population. Oh, hold on. Okay. Other contributing factors for stroke include family history and race. Treatments are available for stroke. Many hospitals are certified stroke centers. Rapid transport is essential. So there's a 3-hour window. That 3-hour window can fluctuate depending on protocols, but definitely you want to get that patient to the appropriate facility within 3 hours of the starting of the symptoms, the signs and symptoms. Introduction. Continuing. Seizures and altered mental status may also occur. Seizures may occur as a result of a recent or prior head injury. Can be as a result of a brain tumor. It can be as a result of a metabolic problem, fever, or genetic disposition. For the altered mental status now. Altered mental status is when a patient is behaving outside of what would be considered normal. So they are displaying abnormal behavior. Possible causes of altered mental status include intoxication, could be the patient has a head injury, could be the oxygen saturation inside of the body is too low, that's hypoxia, could be from a stroke, or it can be from a metabolic imbalance or disturbance, diabetic issue. Anatomy and physiology review. The brain is the body's computer. It is responsible for breathing, speech, and all body function. There are three main parts: the brain stem, the cerebrum, and the cerebellum. The cerebrum is the largest part of the brain. The brainstem controls the most basic functions. This include breathing, blood pressure, swallowing, pupil constriction. The cerebellum controls muscle and body coordination. So balance and coordinated movement is the cerebellum. This includes walking, writing, picking up a coin, playing a piano. The cerebrum is divided into the right and left hemispheres. Each control activities on the opposite side of the body. The front of the cerebrum controls emotion and thought. So emotion and thought is the front portion of the cerebrum. So that's more frontal lobe. The middle controls sensation and movement. That's more parietal lobe. And the back processes sight. That's occipital lobe. In most people, speech is controlled on the left side of the brain, near the middle of the cerebrum. Messages sent to and from the brain travel through nerves. 12 cranial nerves run directly from the brain to parts of the head, eyes, ears, nose, and face. The rest of the nerves join in the spinal cord and exit the brain through a large opening at the base of the skull, referred to as the foramen magnum. At each vertebra, in the neck and back, two nerves branch out. These are your spinal nerves, and we have 31 pairs of spinal nerves. These carry signals to and from the body. And you have your brachial plexus, which nerves branch out in the upper extremity, and the lumbar sacral plexus, where the nerves branch out to the lower extremities. Pathophysiology. So that was a review of the anatomy and physiology. Let's look at the pathophysiology now, the problems. Many different disorders may cause brain dysfunction, right? These may affect the patient's level of consciousness, their ability to speak or understand speech, and their voluntary muscle control. The brain is very sensitive to oxygen, glucose, and changes in temperature. Now, very important general rule. If a problem is caused primarily by disorders in the heart and lungs, then all of the brain will be affected. Very important point. So if the issue is with the cardiovascular system or the respiratory system, all of the brain will be affected. If the problem is specific to the brain, only that area of the brain where the problem is will be affected. Very important slide. Headache. So we're starting off with headaches. One of the most common complaints can be a symptom of another condition or neurologic condition on its own. Only a small percentage of headaches are caused by serious medical conditions. And the headaches that we will be looking at is your tension headaches, your migraine headaches, and your sinus headaches. These are the headaches that are most common, and they are usually not life-threatening, right? The tension is from muscle contractions in the head and neck. So tension headaches will be caused from muscle contraction that occurs in the head and the neck region. Migraine is linked to changes in the shape of the blood vessels at the base of the brain. And your sinus headaches are as a result of changes in sinus pressure from inflammation building up in those spaces or the sinuses. All right, so let's look at them individually. Tension headaches caused by muscle contractions in the head and neck. It is usually attributed or linked to stress. Pain is usually described as squeezing, and it's usually described as dull. Usually do not require medical attention. Then you have your migraine headaches, thought to be caused by changes in the blood vessel size in the base of the brain, experienced both by adults and children. Pain is usually described as pounding, it can be throbbing, it can be pulsating, often associated with nausea and vomiting, and may be preceded by visual changes, right? And some patients will describe the pain as it starts around the eye and one side of the head, and then it starts to spread over to the other side. Can last for several hours or days. All right, the sinus headaches. Sinus headaches are caused by pressure that is the result of fluid accumulation in the sinus cavities. Patients may also have cold-like symptoms of nasal congestion, cough, and fever. Pre-hospital emergency care not required. Now, headache, serious conditions that include headache as a symptom, hemorrhagic shock. So, hemorrhagic shock is linked to headache. Brain tumor. So, brain tumor is linked to headache and meningitis. These are all serious conditions. Be concerned if the patient complains of a sudden onset or severe headache or a sudden headache that has associated symptoms. Suspect stroke in patients with a severe headache, seizures, and altered mental status. Increasing ICP may be caused by hemorrhagic stroke. It can be caused by a tumor or a recent head injury. Now, let's go into stroke. Stroke, also referred to as a cerebrovascular accident, CVA. So if you see CVA is the same thing as stroke. It is an interruption of blood flow to an area within the brain, and this results in a loss of brain function in that particular area. Lacking oxygen, brain cells stop functioning and begin to die within minutes, and brain cells do not regenerate. Time is brain. Once the brain cell die, not much can be done. So, the brain cells develop ischemia, causing them to stop functioning properly. It may take several hours for cell death to occur, several hours or more for cell death to occur. With prompt restoration of the blood flow, the cells will not die and function can be preserved or restored. So time is brain. So if you can get this patient to the hospital within 3 hours of the onset, they will have a good chance of getting back use or function of that area of the brain. But there's a very bad practice in Jamaica where the typical Jamaicans will sit down and watch the symptoms, right? So granny not talking properly or not moving her right hand appropriately, and you say, okay, you know, say she not talk so wonderful or she not move so good on the right side, you know, I could give her some mint tea or some bush tea and watch and see what happens. Then you wait until the following day or down in the night. When it starts to get worse, then they decide to transport granny. But at that point, it's too late. She can't get the medication that she needs to restore any function because the cells have been deprived for far too long of blood flow. So with prompt restoration of blood flow, the cells will not die and function can be preserved or restored. There are two main types of stroke. You have ischemic stroke, which is caused from a clot, and you have hemorrhagic stroke, which is caused from a blood vessel rupturing inside of the head or brain. Now, ischemic stroke is more common than hemorrhagic stroke, so it's most common, accounting for more than 80% of strokes. Result from thrombosis or an embolus, and by now you should know the difference. So a thrombus is a clot that forms in a particular location of the body. An embolus is a clot that breaks off from one area of the body and then travel to another area. So an embolus is a traveling clot. A thrombosis is a stationary clot. Symptoms may range from nothing at all to complete paralysis. And just like how a heart attack occurs, is the same principle. So there is fatty buildup in the cerebral artery. This is atherosclerosis. Over time, this fat hardens and becomes arteriosclerosis. And the patient then has what we would consider to be uncontrolled hypertension. So they have uncontrolled hypertension, and over time, the increase in blood flow is going to tear off a piece of that plaque, and then it occludes the cerebral artery, and the patient gets a stroke, ischemic stroke. So atherosclerosis, plaque forms inside the walls of the blood vessel and may obstruct blood flow. Eventually, it causes complete occlusion of an artery. Hemorrhagic stroke accounts for 13% of strokes. Results from bleeding inside the brain. Cerebral hemorrhages are often fatal. So this has a higher percentage in terms of death rate. People at high risk include those experiencing stress or exertion, and this type of stroke is very common in patients with very high blood pressure. So they are the ones that are at risk. The high blood pressure over time puts a lot of strain on the walls of the artery, and then weak points start to develop in the artery. That is referred to as an aneurysm, and then eventually that aneurysm ruptures, causing a hemorrhagic stroke. So aneurysm, swelling or enlargement of the wall of an artery resulting from a defect or weakening of the arterial wall. Symptom may be the sudden onset of a severe headache. When a hemorrhagic stroke occurs in an otherwise healthy young person, it is likely as a result of a berry aneurysm, and I've already explained what that is. Surgical repair may be possible if care is sought immediately. All right, now let's look at a TIA, which is often referred to as a mini stroke. So transient ischemic attack. The word transient means passing through. So this is a temporary interruption of blood flow to the brain. So the patient presents with stroke-like symptoms, but they disappear within 24 hours. This is referred to as a transient ischemic attack. However, when a patient experiences a transient ischemic attack, it is a warning sign. It is a warning sign that they are at risk for a stroke. So, TIA. When blood flow to the brain is obstructed due to atherosclerosis or a small blood clot, the patient may exhibit signs of a stroke. When stroke-like symptoms go away on their own in less than 24 hours, the event is called a TIA. No actual death of tissue occurs with a TIA. Symptoms of a TIA can last up to 24 hours. May not be able to differentiate between a stroke and a TIA. And also listen for information that pay attention to the information that you are given, because you may be called because the patient was not talking properly or wasn't able to move a limb, and when you arrive, they are able to communicate and move that limb. It could very well be a TIA. They still need to go to the hospital to be examined. Every TIA is an emergency, maybe a warning sign that a more significant stroke may occur in the future. All patients with TIA should be evaluated by a physician. All right, now let's look at the general signs and symptoms of stroke. So your patient can have facial drooping, right? So you're going to use your FAST acronym, right? So in EMS, we call it FAST. These are the things that you must consider for stroke. So you're looking at facial droop, arm drift, right? The S is speech and the T is time. So facial droop, arm drift, speech, and time. How long or when did these symptoms start? That's going to be important. So facial drooping, sudden weakness or numbness in the face, arm, leg, or one side of the body. Decrease or absent movement and sensation on one side of the body. Lack of muscle coordination, we call that ataxia. So when they're walking, they're drifting to one, either the left or the right. They're not stationary, they're not balanced, right? Look for that. Sudden vision, loss in one eye, blurred and double vision, difficulty swallowing, decreased level of responsiveness, speech disorder. They may also have neglect. So the patient may have neglect. What does that mean? It means that the side that the stroke has affected is like their brain doesn't acknowledge that it exists. So it's like it no longer exists for them. That's neglect. They can also have issues naming an object and using an object. Right now, aphasia, they may have difficulty expressing thoughts or inability to use the right words. That's expressive aphasia, right? So they are communicating, but the right words are not coming out. So you ask the patient to repeat for me, today is a cloudy day. And the patient says, the rain is falling. That's not what they want to say. They want to really say what you ask them to say, but it's not coming out how they want it to, right? That's difficulty expressing or inability to use the right words. Then the patient can have receptive aphasia, which is difficulty understanding spoken words. All right, let me flip that around. I don't think I explained that correctly, so come again. The expressive would be more, yeah, I did the right thing. Now, the other thing that can occur is the patient may be able to use the appropriate words, but the words don't come out properly. That would be considered the slurred speech. So that's what we call slurred speech. They can have sudden and severe headache. They can have confusion, dizziness may also be present. They can have weakness, they can be combative, they can be restless, they can have tongue deviation, they can go into a coma. Let's look at the left hemisphere. So stroke in the left cerebral hemisphere may cause aphasia, and it can be linked to expressive or receptive. Right? So they understand what you're saying, they just can't find the right words to explain. Or they completely lost, they have no idea what you're saying. Right? So inability to produce or understand speech problems can vary widely. Stroke may also cause paralysis of the right side of the body. So that's the left hemisphere. Left hemisphere is linked to speech issues and loss of movement on the right side. The right hemisphere will cause neglect, it will cause slurred speech, and it will cause loss of movement on the left side. So the right hemisphere, stroke may cause paralysis on the left side of the body. Usually, patients can understand language and are able to speak fine. However, the words come out slurred. Patients may be oblivious to their problem, that's neglect. Neglect and lack of pain cause many patients to delay seeking help. Bleeding in the brain. Patients may have high blood pressure. The high blood pressure may be the cause of the bleeding. It may be caused by the bleeding as a compensatory response. If increasing blood pressure is an important sign, so pay attention to the blood pressure. Significant drops in blood pressure may occur as the patient condition worsens. Monitor the blood pressure for changes. Conditions that may mimic stroke. So there are conditions that can mimic stroke. Hypoglycemia, not enough blood glucose, so that's one. 2, Postictal state of a seizure. So this is the phase of a seizure where the brain is resetting. Right? Period following seizures that last between 5 and 30 minutes. Characterized by labored respirations and some degree of altered mental status. A patient with a subdural or epidural bleeding, blood near the skull presses on the brain. These patients can present as if they are having a stroke. All right, now let's look at seizures. So seizures, this is a neurologic episode caused by a surge of electrical activity in the brain. It can take the form of convulsion, or it can be associated with a temporary alteration in consciousness. So there are two basic groups for seizures. You have generalized and you have partial, which is a focal seizure. Generalized and partial. And this used to be called grand mal and petit mal seizures. Let's look at generalized seizures. So generalized seizures result from abnormal electrical discharges from a large area of the brain. It is typically characterized by general unconsciousness and a generalized severe twitching of all the muscles lasting several minutes or longer. It may simply be characterized by a brief lapse of consciousness, right? That's an absent seizure. So it can be a seizure in which you can see the muscle twitching and the rigid contractions at the body, or it can be a generalized seizure where the patient's brain for a brief moment goes blank, right? That's an absent seizure. For the partial seizure, it can be simple, can be a simple partial seizure, or it can be a complex partial seizure. And these are localized or focal seizures. With a simple partial seizure, there is no change in the patient's level of consciousness, right? They may have numbness, they may have weakness, dizziness, visual changes, or unusual smells, tastes, and they may have some twitching or brief paralysis. That's a simple partial. A complex partial seizure will cause altered mental state, right? So it's going to cause an altered mental status. So that's the difference really between a simple and a complex partial seizure. So complex partial seizures cause altered mental status, result from abnormal discharge from the temporal lobe of the brain. You'll see lip smacking, eye blinking, isolated jerking. Patient can complain of verbalize unpleasant smell. They can have visual hallucination, uncontrollable fear. They can display repetitive physical behavior. That's partial. So again, your partial can be simple, simple meaning no change in level of consciousness, or complex, meaning there is altered mental status, but the patient is not unresponsive. So the patient is not completely unresponsive, but they are displaying an altered mental status. Once consciousness goes with a seizure, that is generalized. All right, now most patients will complain of a aura. So patients that have been diagnosed with epilepsy normally know when they're going to have a seizure, right? So they go through what is referred to as a aura. Aura occurs, and it might not happen for everyone, right? It can be a visual change, can be hallucination, it can be an unusual smell, something that they're hearing, and then they go through the phases of the seizure. Aura. Patients may experience an aura prior to a seizure. Can include visual changes or hallucinations. People with a history of seizures recognize their auras and usually take steps to minimize injury. Auras do not occur prior to every seizure, and not all patients with a seizure disorder will experience an aura. All right, now generalized seizures. These seizures are characterized by a sudden loss of consciousness. There is chaotic muscle movement and tone and apnea. May exhibit bilateral muscle movement characterized by a cycle of muscle rigidity or contraction and then relaxation, and this usually lasts 1 to 3 minutes. Tachycardia, hyperventilation, sweating, and intense salivation may occur. Most seizures last 3 to 5 minutes. And they will have a phase which is referred to as the post-ictal state. That's 5 to 20 minutes. And this is the phase in which the brain starts to reset and the patient gradually regains their level of consciousness. We call that the post-ictal state. And usually you find them snoring deeply in that phase as they try to get rid of the acids that has built up in the body. They're balancing out their pH at that point. Then you have the absent seizure now. Now, this particular seizure is not easily identified. You're going to see it in your pediatric population, right? So because it's only affecting the level of consciousness and not the muscles, it might be difficult to pick up, right? And what the kind of information you're going to get is the child was carrying out some type of activity. So the parent or guardian probably tell the child to pass something or do something, and in the middle of that action, the child stops, drop whatever they have or holding at that point, and then the brain chips in back, but they don't remember the instructions that they got, right? So they can't remember anything. The brain just chip out and then chip back in. That's a absent seizure, and depending on where the child is, that can be a problem, because if the child is on the jungle gym and the brain chip out at that point, they're going to drop off. Now you have two problems: possible seizure and traumatic injuries. So formerly referred to as petit mal, may last for seconds. Patient fully recovers with a brief lapse of memory. Now, then you have your status epilepticus. So for textbook purposes, seizures lasting more than 5 minutes are likely to progress to status epilepticus. In generally speaking, what status epilepticus is, this is a seizure in which the patient does not regain consciousness. So it's constant seizures without the patient regaining consciousness. What do I mean by that? So the patient gets a seizure, seizure stop, post-ictal state, seizure, post-ictal state, seizure. So the patient brain is not recovering and they're continuing to have seizures. That is status epilepticus. This is a patient that is going to require medications to stop that seizure. So status epilepticus, seizures lasting more than 5 minutes are likely to progress to status epilepticus or status epilepticus. Pronunciation varies. Seizures that continue every few minutes without the person regaining consciousness or last longer than 30 minutes are referred to as status epilepticus. All right, now causes of seizures. It can be a structural issue, can be congenital, which is epilepsy, can be structural, which is tumor, benign or cancerous, can be infections, brain abscess, scar tissue, head trauma, stroke. It can be from metabolic issues, hypoxia, abnormal blood chemical values, hypoglycemia, poisoning, drug overdose, sudden withdrawal from alcohol or medication. It can be febrile seizures, which is common in a pediatric population. So some seizure disorders are congenital. That's epilepsy. They have been diagnosed with it. Others may be caused by high fever, structural problems, brain or metabolic or chemical problems. Epileptic seizures usually can be controlled by medication, and these are the medications that these patients are usually taking or may be given, right? So wherever this is in your book, make sure you make a note of that. These are medications for you to be familiar with. Not in the sense that you're going to help the patient take the medication, but when you see it, you know that this patient probably has a history of epilepsy. All right, now causes of seizures. Seizures may be caused by an abnormal area in the brain, structural cause, such as a benign or cancerous tumor. Benign means it doesn't spread, cancerous means it can spread. And these patients can have unusual generalized seizures, right? So a patient with a brain tumor can have a seizure and they know that they're having a seizure, meaning they don't fully lose consciousness and their entire body is shaking and they can't control it. I have seen that in my experience. It can be caused from infection, brain abscess, meningitis, scar tissue from some type of injury. Seizures can be caused from metabolic issues, so abnormal levels of certain blood chemicals, right? Hypoglycemia, poisoning, drug overdose, sudden withdrawal from routine heavy alcohol or sedative drug use. Prescribed medications. Seizures can also result from sudden high fevers, and that's common in children. The importance of recognizing seizures. Recognize when a seizure is occurring and whether this episode differs from previous ones. Patient may turn cyanotic. Seizures may prevent the patient from breathing normally, so be prepared to manage the patient's airway. not during the seizure, in the postictal state. In a patient with diabetes, the blood glucose level may decrease. If protocol allows, monitor blood glucose level after a patient with diabetes has a seizure. Look at other problems associated with the seizure. Patients who have fallen during a seizure may have a head injury. Patients having a generalized seizure may also experience incontinence. All right, the postictal state. After a seizure, the muscles relax, becoming almost flaccid, and breathing becomes labored. So they start to breathe very, very rapid and deep because they're trying to balance out the pH based on the activity that went on. This breathing pattern helps the body to balance the acidity in the bloodstream. With normal circulation and liver function, the patient will begin to breathe more normally within minutes. Now, during the postictal phase is when you will provide most of your management. You cannot physically stop a patient from having a seizure. You should never physically attempt to stop a patient from seizing. So what is happening to the patient? They cannot control it. So you definitely physically cannot control that either, right? The brain is firing off impulses too rapidly into the muscles. You can't physically stop that. Don't try, right? Clear the area that the patient is in. If they're in their home, clear the area. On your stretcher, loosen up your straps, make sure the patient don't fall off the stretcher. But do not physically try to restrict the patient's movement. That's not how we manage seizures. Let the patient have the seizure. When the seizure stops, do your assessment. Make sure check their LOC, make sure their airway is clear, make sure they are breathing. Manage any injuries that you need to at that point. Do not put anything in the patient mouth, right? So do not put anything in the patient mouth or try to put anything in the patient mouth when they're seizing or having the seizure. All right. So the postictal state may be characterized by hemiparesis resembling a stroke, most commonly characterized by lethargy and confusion, lethargy, weakness. Patient may be combative. Be prepared for these circumstances. If the patient condition does not improve, consider the possibility of an infection or low blood sugar. Syncope or fainting. Seizures are often mistaken for syncope or fainting. Fainting typically occurs while the patient is standing. A seizure can occur from any position. Seizures may occur in any position. Fainting is not associated with a postictal state. So you're not going to see a postictal state with fainting. Fainting is simply a temporary loss of consciousness due to decreased blood flow to the brain. Once the patient goes flat and the blood flow returns, the patient wakes up. That's fainting. Altered mental status. Aside from stroke and seizures, the most common neurologic emergency is going to be altered mental status. Patient is not thinking clearly or is incapable of being aroused. In some cases, the patient will be unconscious. In others, the patient may be alert, but they are displaying signs of confusion. And anytime you have a patient with an altered mental status, you need to find out what is considered normal for this patient and when was the last time this patient was seen behaving normal. How long has this been going on? These are important things to find out. Causes of altered mental status, hypoglycemia. Patient can have signs and symptoms that mimic stroke and seizures. May have hemiparesis. A patient who has had a stroke may be alert and attempting to communicate. A patient with hypoglycemia almost always has an altered or decreased level of consciousness. Patients commonly, hypoglycemic patients or hypoglycemia patients, often take medications that lower the blood glucose level. Patients can also experience seizures. The mental status is not likely to improve even after several minutes. Consider hypoglycemia in a patient who has AMS after an injury such as a motor vehicle accident or crash. All right, now delirium. Delirium is a symptom, not a disease. Presents as a new complaint, temporary state that may have a physical or mental cause, such as infection, changes in medication, or hypoxia. May be reversed with treatment. So delirium is the patient is displaying unacceptable behavior, right? Or unacceptable ability to reason. That's delirium. But it can be linked to medical issues. And if you can fix the medical issue, then you fix the delirium. Signs and symptoms. Rapid alteration between mental states. Symptoms may mimic intoxication, drug abuse, or severe psychological disorders. Other causes of AMS. Considerations of other possibilities become important because a patient with altered mental status may be combative and refuse treatment and transport. In most cases, a patient who appears intoxicated is just that. So in most cases, a patient that appears drunk is usually drunk, right? Psychological disorders and medication complications are possible causes. Infections, particularly those involving the brain or bloodstream, may be a cause of AMS. Now let's look at the patient assessment. So start with your scene size up. Focus on scene safety. Dispatcher may be able to provide a description of the patient's problem, or they may not. Patients with AMS may exhibit a wide range of signs and symptoms and behavior. Do not be distracted by seriousness of the situation or frighten family members. Consider the need for spinal motion restriction. Look at the mechanism of injury or nature of illness if present. Look for clues to determine the NOI. Special considerations for a patient with a suspected neurologic emergency. An evaluation of the environment for signs of potential trauma must be done. Indications of previous medical conditions. So look for indications or indicators for previous medical condition. Is there evidence of a seizure? Ask family when was the last time the patient appeared normal, and if they are displaying altered mental status, find out if this is normal. Is this normal for the patient? If not, when was the patient last seen behaving normal? After you've completed your scene size up, next is your primary assessment. Look for and treat life-threatening conditions. Perform a rapid exam. Ask as you approach the patient, gather information from the scene, note the patient's body position and level of consciousness. Initial impression will help you to determine the severity of the situation. You should be able to tell if a seizure took place use the AVPU scale. So that's your general impression, level of consciousness. The next phase is going to be airway breathing. We know this by now. Patients may have difficulty swallowing, choke on their own saliva. Be prepared to provide suction, especially for your patients who are unresponsive or in the post-ictal state of a seizure. Be prepared to provide suction. Position the patient to prevent aspiration. Ideally, if there's no spinal issues, we want that patient in recumbent position on their side or recovery position. Position the patient to prevent aspiration. Check for foreign body obstruction. Assess the patient's breathing. All patients with an AMS, regardless of the cause, you need to be thinking about giving that patient high flow oxygen. Airway and breathing continued. Ventilate the patient at the proper rate with proper volume. Deliver each breath during a period of 1 second at a rate of 10 to 12 breaths per minute. That's if you recognize that there is a ventilation problem. Do not hyperventilate your patient. Hyperventilation may have negative consequences. It can cause a decrease in the patient's cardiac output. It puts the patient at risk for regurgitation and aspiration. So it can force air into the stomach, and that pushes the stomach contents up, and the patient can aspirate that. Further injury to the brain in patients with intracerebral bleeding and increased intracranial pressure, right? So you can cause the cerebral blood vessels to vasoconstrict if you give too much oxygen. We don't want that happening in a patient that needs oxygen to the brain. All right, now after you have assessed and managed your upper and lower airway issues, then the focus will shift to circulation. Check the pulse if the patient is unresponsive. If no pulse is found, then we need to start CPR and get an AED attached, or switch your cardiac monitor to AED mode, put it on the patient as quickly as possible. If the patient is responsive, determine if the pulse is fast or slow, weak or strong. Evaluate the patient quickly for external bleeding. Yes, so even if it's a medical patient, we still look for bleeding. A medical patient can bleed. So they can have medical conditions that cause them to bleed excessively. Transport decision. So after your ABCs, based on the findings, based on your management up to this point, is this a load and go patient? Is it a stay and play? Transport decision. Establish priorities based on your assessment of the patient's level of consciousness and ABCs. If the patient is experiencing a stroke, rapidly transport to an appropriate facility. Once you package your patient and put the patient in the back of your unit, if your patient is talking to you, it's time to get some information. And you may have started to get some information before you even put the patient in the back of the unit. So you need to get some information, then you do your vitals. Not talking to you, then you focus on the patient, try and get information from bystanders. Investigate the chief complaint. So we're at the history taking phase. Investigate the chief complaint for unresponsive patient. Gather any history from family or bystanders. And remember, if they cannot give you clear information, you are going to check pupils, blood sugar, O2 sat, and make sure that you do a rapid scan on this patient. If no one is around, quickly look for explanations for AMS, stroke, hemiparalysis, or one-sided weakness, seizure, incontinence, or biting the tongue. Ask a responsive patient what happened. Evaluate a responsive patient's speech and whether or not they understand what you're asking. Get a sample history. Time is critical. Time is brain. So with a possible stroke patient, you have a 3-hour window from when the symptoms start, and they contact you, you reach, provide treatment, package, transport to the healthcare facility. You want to get all of that activity within 3 hours. That's going to give the patient the best chance of restoration if it is a ischemic stroke, a stroke caused by a clot. Try to determine the exact time the patient last appeared healthy. Collect or list all medications. Ask if the patient has a history of seizures. Ask if this episode differs from the previous episodes and what medications the patient takes. If not, a serious condition should be suspected. After your history taking, next phase is secondary assessment. Physical examination, full body secondary assessment, paying special attention to system involved, so it's going to be systematic. If you suspect your patient is having a stroke, direct particular attention to neurologic assessment. So you need to look for your facial droop. You ask the patient to hold the arms out, palms up, close the eyes, and you watch to see if one side move any at all or one side is weak. That's arm drift. And you give them a simple phrase to repeat. Repeat for me, today is a sunny day, right? So facial droop, arm drift, speech, and time. If they are not behaving normal, when was the last time they were? All of this is important. Any other assessment you want to include outside of that? Vital signs. Significant intracranial bleeding leads to a great deal of pressure in the skull compressing the brain. This is going to cause the pulse to slow and cause erratic respirations. Remember your Cushing triad. Bradycardic pulse, elevated blood pressure, irregular breathing, or slow breathing. Blood pressure is usually high to compensate for perfusion, and the patient might have unequal pupil size and reactivity. This will indicate severe or significant bleeding or pressure building up on the brain. If the patient has an altered mental status, we definitely need to check blood glucose. We definitely need to check pupil reaction, and we should be looking at the pulse ox reading, and we will compare that to what we are seeing as it relates to the patient presentation. During most active seizures, it is impossible to evaluate vital signs, and this should not be your priority. I've already explained that. We do not try to control movement of a patient when they are having a seizure. Let the seizure run its course. When the patient goes into the post-ictal state, this is where we work. We will work quick, we will work fast during this phase. In most cases, vital signs of a patient in a vital signs of a patient in a post-ictal state will be close to normal limits. All right, stroke assessment, talk about that already. Rapidly identify stroke in the field with a stroke scale, and you will be guided by the type of assessment tool that your organization uses. You have several, right? So stroke scales evaluate face, arms, and speech. You have the Cincinnati Prehospital Stroke Scale. You have the Los Angeles Prehospital Stroke Screen. You have the 3-item Stroke Severity Scale, LAG, look at the level of consciousness, arm drift, and gaze. So your company will decide whichever one they want to use, right? But remember, these are the core things that these assessment tools must focus on if we suspect stroke. Is there facial droop? weakness? Is weakness present on one side of the body? Arm drift. Is this patient able to understand and produce speech properly, right? If the patient is showing abnormality, when was the last time the patient was seen normal? These are important things to consider for a stroke patient. You definitely need to also be focused on the GCS. So you got to do the GCS, and this is something now that you are going to put on a flashcard and walk around with until you learn it. Because when we meet face to face, whichever patient I give you, I will expect you to be able to calculate the patient's GCS and tell me what you think the patient's GCS is. So now it's time for you to learn that. All right, now reassessment. Focus on reassessing the ABCs, vital signs, and intervention. Stroke patients can lose airway or stop breathing without warning. Interventions, multiple interventions may be necessary. Airway adjuncts should be considered, positive pressure ventilation, other treatments, right? Compare baseline information with updated information. Notify the receiving facility of patient's chief complaint and assessment findings. You're gonna be doing your communication and your documentation. Call a stroke alert to designated stroke centers. Be sure to communicate time that the patient was last seen healthy, findings of your neurologic examination, time you anticipate arriving at the hospital. These will be important, right? And the treatment is expensive, but because the University of the West Indies is doing research as it relates to that particular medication. Once the patient meets the criteria for the medication, they will not deny it, right? So the medication is at the University of the West Indies. And I think a couple of years ago, maybe 3 years ago, it was 500,000 for that particular meds. I don't know what the cost is now, right? But it was 500,000 at that time to actually give the medication. All right, now for patients who are having a seizure, give a description of the seizure activity if known, right? That's if you witness. If the patient has a history of seizure activity, determine how often the seizure occur and if there is any history of status epilepticus. Document intervention and the patient's response. All right, now let's look specifically at the emergency medical care. Some conditions are easier to identify than others. Cause of other neurologic emergencies may not always be obvious. ED physicians determine if there is bleeding in the brain for patients with suspected stroke with a CT scan of the head. Blood clot dissolving medication may be given if there is no bleeding. So if they realize that it's not a hemorrhagic stroke, then the patient may be a candidate for blood clot dissolving medications. Notify the hospital staff. Treatments are available if started right away. Communicate the last time the patient was known to be well. Patients who have had a seizure require definitive evaluation and treatment. Supplemental oxygen is strongly advised. If once it's necessary, you give it. For patients who are having a seizure, protect them from harm, maintain a clear airway by suctioning, provide oxygen as quickly as possible. If head or neck trauma is suspected, then you need to consider spinal motion restriction. For patients who continue to have a seizure or you suspect is in status epilepticus, suction the airway, provide positive pressure ventilation, transport quickly to the hospital, rendezvous with an ALS unit, right? And remember, your management will take place in the post-ictal state. Emergency medical care for headache. Most headaches are harmless and do not require emergency medical care. You should be concerned if the patient complains of a sudden onset of severe headache, a sudden headache with fever, seizure, AMS, or following trauma. Always assess the patient for other signs and symptoms that might indicate a more serious condition. Apply high flow oxygen if tolerated. Provide a darkened, quiet environment. Do not use lights and sirens during transport. Emergency medical care for stroke. Support ABCs and provide rapid transport to a stroke center. Patient may require manual airway positioning. The ideal position is recovery, and you are going to put them on the side that they cannot use. So don't put them on the side that they can use, right? Don't put them on them good side. Put them on their bad side. Use suction as needed and monitor the patient's oxygen saturation. We want a O2 sat of at least 94%. Oxygen therapy not recommended unless you are seeing signs of respiratory distress or hypoxia. So if the patient is not showing any signs of respiratory distress or signs of hypoxia, they do not need oxygen. If you give them oxygen at that point, it can cause more harm than good. Paralyzed extremities will require protection from harm. Keep the patient informed. Thrombolytic therapy may reverse stroke symptoms if the patient meets that 3-hour window. And as I said, that will differ based on protocols. But generally, you want to get them to the hospital within that 3-hour window. Okay, so I was saying, the side that the patient cannot use, that's the side you place the patient on. So if the patient can't use them right side, you put them on their right side. If the patient can't use the left side, put them on the left side. That's the best way to protect it, and they still have the ability to maneuver with the good side. So that's what I was saying. All right, spend as little time as necessary. Spend as little time at the scene as possible. Stroke is an emergency. I think I've overemphasized that. Time is brain. Time is brain. If possible, transport to a designated stroke center or a hospital that has the capabilities to deal with a stroke patient. The patient, for seizure patient, the patient may be in a post-ictal state upon your arrival. So you may find the patient in that phase. LOC, airway breathing circulation. Pay attention to them airway, right? So make sure that the airway is clear. The patient may still be having a seizure when you also arrive. Don't freak out. So if a patient starts to have seizures, do not freak out. right? Don't freak out. Right, so continue to assess and treat ABCs. Try administering oxygen. Right. So thrombolytic is basically a medication that is given via IV route. It's going to break up the clots. That's it in a nutshell. I'm not going to go any deeper than that, but it's the medication that is going to break up the clot, but it has to be given within a specific time frame. That's what thrombolytic therapy is. All right, now it is difficult to safely prepare a patient for transport who is having a seizure. Assess for trauma, use spinal motion restriction if indicated. Never attempt to restrain a patient having a seizure. Hold on. Let me check something really quickly. All right, so not every patient who has had a seizure wants to be transported. So you may have that issue, right? I had a particular patient when we got there, just as we reached, she was having a seizure. Went into our Postictal State, gave her some meds. She recovered. After she recovered, she didn't want to go to the hospital, so I had to spend some time trying to convince her to go. And she eventually went. And I've had a patient that had a seizure, recovered, got to the hospital, and as soon as I reached the hospital, right, and I was coming out to go around the back, well, I came out from the side to go around the back after releasing the straps and the stretcher. Patient opened the door and went straight through the gate. And patient went straight through the gate. So be prepared for that. Be prepared for that. So not every patient who has had a seizure wants to be transported. Your goal is to encourage the patient as best as possible to be seen by a physician. Be prepared to discuss the situation with hospital staff. All right, now signs and symptoms of your altered mental status will vary from simple confusion to coma. AMS is always an emergency that requires immediate attention, even if the cause appears to be intoxication or a minor head injury. And that would bring us to the end of this chapter, neurologic emergency. Why would you want to put something in a patient mouth to bite on? And which patient are we talking about? A seizure patient? Are we talking about a seizure patient? Whoever asked, that was Mr. Right, so why would you want to put a bite block in a patient mouth that's having a seizure? What's the rationale for that? Explain that to me. Let me see if it's logical or not. So why would you be thinking of doing that? What's the rationale? What's the thought process behind that? Quickly explain. Where did you say prevent the patient from biting their tongue? Did you see that in any of the slides that I presented? All right, so as I stated before, seizure is muscle control that is beyond the patient's control, right? So the muscles are moving. The patient cannot control that. If you put a bite block, that's not going to stop them from biting. What happens if that patient bites off piece of the bite block? What is going to happen? You know, have a patient with an airway obstruction, right? So that's a no-no, right? Clear the airway of secretions. They will bite their tongue. It's gonna happen. You can't physically stop that. It's gonna happen, right? Can't put anything in the patient mouth to stop the muscles in the mouth from moving. It's gonna move once the abnormal impulses are firing. No problem, I understand, right? So just understand that it is a activity which the patient body cannot control. The patient cannot control it. The only thing that can physically stop a seizure is medication. That's the only thing that can stop it. So if they're biting, if there's lip smacking, there's nothing you can do to physically do that. And if you try to do something to physically stop that, you may cause more harm than good. Right? So be mindful of that, right? So this might mean that you may have to, based on what you're observing, you may have to use positive pressure without an airway adjunct, right? Or you might be geared towards more using a NPA than an OPA. So these are things that you will have to consider for your seizure patient. It's too dangerous, it's too risky to try anything physically to stop what they're doing. All right, so that's the end of the chapter. Let me